It's now my pleasure to introduce Dr. Mishka Terplan, who is a professor of obstetrics, gynecology, and psychiatry. He has a master's degree in epidemiology and is a diplomat of the American Board of Addiction Medicine and is Distinguished Fellow of the American Society of Addiction Medicine. Mishka is an excellent scholar. He publishes, has had multiple grants. He runs our new Motivate Clinic, which is a clinic whose population has risen like this since we opened it last year. It's a brand new clinic. We're running out of space. We're adding faculty. There are so many people who want and need help. The thing that I want to tell you about Mishka is that in addition to all of his awards, he is a stellar clinician. He really cares about the people that he takes care of. And that is an old-fashioned tradition of medicine that sometimes is lacking. But this guy really cares about what he does and the individuals he takes care of. So it doesn't matter whether it's 9 o'clock in the morning or 9 o'clock at night or 3 a.m. He's there for the folks he takes care of, and that develops in me tremendous respect. He's going to be talking to you today about the health effects of alcohol, marijuana, and opioids, the real deal. And part of what I hope he's going to tell you is that it's not just the opioid crisis. We continue to have problems, significant problems with other substances. So, Mishka, thank you very much. Do it.
Great, thank you. Thank you for inviting me. Thank you, everybody. I have some notes. I have a timer. Not looking at my email. I was gratified to hear President Rao talk about the human condition, because that's actually a little bit that I wanted to talk through, put some historical context to talk about sort of the difference between substance use, harmful use, and addiction. And really, there's been some cross-cultural anthropology looking at societies through place and time. And every single human society, aside from one, has been described as using a psychoactive substance. And the one that didn't lived on an island in Papua New Guinea where there were no plants that produced ethogens, chemicals in plants that have a cognitive effect. And so we think actually about substances as being part of human history. And this is a map from National Geographic looking at places where alcohol was fermented and where it was transported. And you can see almost all of the continents, aside from North America and parts of Southeast Asia and Australia, had 10,000 years ago were using alcohol. And in fact, lots of different, it wasn't just grains. Grains emerged later. There are all sorts of different plants, fruits, and even like the milk from mammals that were fermented. And I want to say that these early drinks were very low alcohol, probably less, 1, 2, 3% alcohol, but still alcohol. And the oldest actually come from China. There's a field called molecular archaeology, looking for traces of substances in archaeological remnants. And we have found, or these researchers have found, parts alcohol remnants dating back, almost 10,000 years. And alcohol is depicted in old, literatures, both health and sort of cultural documents. And the same is for cannabis. It's a plant, grew like native-wise throughout Southeast Asia and into like what's Middle East, and is almost every sort of historical medical tradition describes cannabis. Indian, Chinese, Sumerian, and etc. And including Egypt. So this is Seshat, who was the goddess of wisdom, knowledge, and writing, thought to be the inventor of writing, and is always depicted with a cannabis leaf like above her head, in part perhaps because of hemp, because the earliest papers, were made from hemp products. Similarly, when we think about opioids, it's actually women who are depicted in the archaeological remnant associated with opioids. This is a figure found in Crete called just the poppy goddess. A lot is not known about this culture, but what is thought is that this goddess was the precursor to Demeter. And we think about Demeter, the goddess of reproduction, the goddess of agrarian society, reproduction, harvest, always depicted holding grain. But as you can see, she's also always depicted holding opioids, something that we've kind of, sort of lost, I think, in our record. So psychoactive substance use is ancient. It's part of human culture. But the idea and the emergence of drug problems, and in particular addiction, this is actually a more modern phenomena. And it dates really, you can argue over when, but perhaps sometime in the 16 to the 1700s. And some of the first descriptions are around alcohol. And how I said before, the early, the culture, the drinks, even in early America when people brewed cider and beer, it was low alcohol, a couple of percentage. But with distillation, we began to create higher, more potent drinks that led to problems, especially in urban environments. And the real sort of first socially recognized drug harms and the first descriptions of what we might call addiction emerge from this period of time. And the first person to really describe addiction as a disease was Dr. Benjamin Rush, who's one of the signers of the Declaration of Independence and is the father of psychiatry and the father of addiction medicine, who first described alcoholism as a medical condition. He called it a disease of the will, but he described the features of compulsive use, continued use despite adverse consequences, which really remain the diagnostic core of all substance use disorder today. So that was really, alcohol was the first kind of epidemic of substances in the world and certainly in the United States. And Benjamin Rush's descriptions were highly influential. And this is a quote from President Lincoln addressing the Springfield, Washington Temperance Society in 1842 that really speaks to what other people have mentioned, which is stigma. The victims to its spirits were pitied and compassionated, just as they are now other hereditary diseases. In my judgment, such of us as have never fallen victims, have been spared more from the absence of appetite than from any mental or moral superiority over those who have. So the idea that creation of this concept of addiction as a medical condition lays the groundwork for approaching people who suffer from the illness with compassion, with dignity, with respect, as illustrated by this quote. So in the late part of the 1800s, we have the emergence of the first opioid epidemic in the United States that featured overwhelmingly women, white upper class or upper middle class women who were addicted to opioids that were prescribed to them by their physician for the treatment of female ailments, pain, menstrual irregularities, etc. And you can see here, laudanum is a name it's opium that's dissolved in alcohol, and you can see on the label that it's intended for women and children. Alcohol was the province of men, and the substances, opioids, cannabinoids, etc., were actually marketed explicitly to women. And this is the first opioid epidemic in the United States, and it was understood through the lens of alcoholism. In fact, it was called morphinism, and this is a textbook from 1902 talking about the relationship between gender and the development of opioid addiction. Capriciousness of mind, irritability, selfishness, restlessness, and excitability are the natural characteristics of many women who quickly become morphinists, especially if under treatment for disorders of the generative organs. So I can talk a lot about this. There's lots of parallels between this crisis and the current one. It's iatrogenic, it features women prominently, and et cetera. But I wanted to talk about this, so a hypodermic needle invented in the 1840s, it rather quickly picked up for self-administration of morphine. And this is the oldest image I've ever found of anyone injecting a drug. And it's an image of a woman injecting morphine. An image so common that it was reproduced in postcards. This is a postcard you could have purchased on the streets of Paris in the early 1900s. So addiction was understood this way, through the lens of Dr. Benjamin Rush, as a disease, as morphinism, and it was treated. All that we had at that time were short-acting opioids, and short-acting opioids were used for the treatment of addiction to opioid use disorder. And there were specialty clinics. In fact, there were, at one count, at least 44 sort of opioid treatment clinics run both by public health departments and also by police departments in the early part of the 20th century. Yes, yeah. Yes. So that the half-life is short. So morphine, heroin, some of the codeines are short-acting. So you take it, it peaks and goes away within hours. Methadone, buprenorphine, which are two medications we use to treat opioid use disorder, are long-acting opioids. People are dosed once a day. So there were no long-acting opioids at that period of time, which is why short-acting opioids were used. So this all changes, right, with the Harrison Narcotics Tax Act of 1914, which really regulated the manufacture and sale of narcotics and licensing of sort of the nascent medical and pharmaceutical practice. And there was language in this act that permitted the dispensing of opioids to a patient in the course of the physician's professional practice only. And what that phrase meant was argued through a series of Supreme Court decisions, where on the one hand, Treasury, which was the federal branch sort of designated to enact the Harrison Narcotics Tax Act, argued that giving somebody with an opioid use disorder opioids was not in the course of the physician's practice. And the nascent medical society at the time said, no, this is what we do, we've got some literature on it, and the physicians lost. And this Harrison Narcotics Tax Act rendered the prescribing of opioids for the treatment of opioid use disorder illegal. And all of those clinics that had emerged were shuttered. And there were some, 20,000 physicians who were fined for being in violation of this act. And the course of addiction treatment in the United States shifts kind of incredibly. And who a person is, who we think of culturally with a drug problem, shifts too. Addiction goes from medical to criminal justice, and to some extent goes from female to male. So following this tax act, using drugs became illegal, and people were arrested. And this is a newspaper clipping, and it was sort of news there were 88 people arrested, in one night in New York City, and the cameras are there sort of like snapping photos of all these people, most of whom had opioid use disorder. And the prisons were filling up. So what are we going to do about it? So what developed what was called the U.S. Public Service Hospital, both in Fort Worth, Texas, and in Lexington, Kentucky, also called the Narcotics Farm.
Mr. Chair, I don't want to interrupt your narrative. When you say prisons are filling up, can you give us some notion of the order of magnitude in relation to today?
Oh, pales in comparison. So the prison population.
A tenth as many, a hundredth as, I mean.
So for, off the top of my head, no. We've had, I can get back to you.
I understand
on
it's a smaller country then, smaller population. But,
yeah.
Okay.
But this was a noticeable change in jail and prison populations. at the time.
Was this something that was affecting all strata of society, or was it limited to people with money, or the opposite? It was something that was taking place. This was the famous era of slums. I mean, was it?
Yeah,
Did they find that it was
That's a great question.
mostly somewhere?
So in terms of who gets, there's a difference between who has what we call a substance use disorder and who gets sort of maybe picked up by the police for having a substance use disorder. So the risk factor, I'll talk about this shortly, but one of the things you can say about addiction is that everyone is at risk. Some people have greater vulnerabilities than other people to it. How policing works is not equally distributed across, a population. And so some people are more likely to be identified, caught up, and incarcerated than others.
I'm sorry, Mr. Chair, one more, just so I don't interrupt you
Yeah.
again. What you're describing is something that most of us have some familiarity with, the year 2018. Was that also, what I'm getting at, the people that were being brought into prison back in the day, in the period you're describing,
So
were they generally representing?
Somewhat, to some
Was
extent.
it very expensive and therefore only the wealthiest could afford it? Was it just the opposite?
No,
Was
so
it somewhere in the middle?
these are the only two treatment facilities for most of the 20th century in the United States. And lots of people passed through them. It was almost became a rite of passage for jazz musicians to spend time at the farm. Billie Holiday spent time there. There's a lot of, very, cultural icons in the United States with who had opioid use disorder who spent time there. There still was addiction that didn't go through here that was somewhat taken care of by private medical practices, but this is also the period of time that AA emerges and the 12-step program, sort of the vacuum that was left from the Harrison Narcotics Tax Act. Addiction continues and people engage in sort of self-cure rather than institutional cure. So this is a picture of people, and some of them are actually from Richmond, Virginia, which is why I show it, who have to, in a sentencing hearing, raise their hand to say, I am a drug addict, so that they can go to get treatment in the facility. And this is then how, to some extent, this is like a newspaper, that it was, despite the sort of criminal justice thing that I was talking about, this was viewed through the lens of victims of drug addiction going to the federal narcotics farm and the benefit of sort of public enlightenment, right? So I want to talk about this, the context, to talk about sort of health effects and really begin with the question, why do people take drugs? There's a historical piece, a cultural piece that I mentioned, but we think about it to feel good, to feel better, to do better, to fit in, and because of that sort of basic, human, animal, curiosity. So if people take drugs, taking drugs makes people feel good or better, makes people do better, what's the problem, right? It's somewhat a rhetorical question. But some of the problems relate to harms, to addiction, and we can classify use to sort of help us think about this. Some people don't use substances or use at a very low level, which confers a low risk. Some people have a use disorder. That's the top of the pyramid, and they need treatment for the use disorder. And then there's a category of people in the middle who have sort of harmful use or risky use. And as you can see from here, it's been described more with alcohol. About 40% of the US population doesn't drink. An additional 35% drink at a low level. That would be for women, 7 or fewer drinks a week, for men, 14 or fewer, and no more than a couple of drinks in a sitting. About 20% of the US population drinks at a higher level. That's both binge alcohol consumption or heavy alcohol consumption. And about 5% meet criteria for a use disorder. So this kind of pyramidal representation of use in a population, which we know more for alcohol than other substances, is super helpful in thinking about public policy and public health responses. So at the top, that's treatment. If you have the disease of addiction, you need treatment. But there are many more people with unhealthy use than there are with addiction. So in that bigger, like egg-shaped sort of population in there, that's where we talk about early intervention. That's when we talk about screening and using brief interventions, motivational techniques to motivate somebody to change their behavior, to decrease their drinking, let's say, to a non-drinking or a low level of risk. This is also where we think about sort of educational campaigns or early intervention, as it's been brought up a bunch of times, for adolescents, young adults, and even people sort of younger than adolescents. So this is sort of the population health way of approaching harms and substances. So by substance, this is a poster looking at the harmful effects of alcohol. And really, it's like system-wide. They're metabolites of alcohol that exert a toxic effect, in particular on the liver. That's what we think about a lot, but also on the heart, on blood pressure, weakening the heart muscle. In general, alcohol actually weakens muscles, preferential towards fat distribution, less muscle. People who drink also tend to have their entire GI tract, especially gastritis, the pancreas, pancreatitis, and suppresses the immune system. So individuals who are heavy alcohol consumers are actually more likely to develop infections, have a harder time clearing them, and et cetera. Probably the oldest sort of negative descriptions of alcohol relate to the brain, to sort of toxic effects of chronic heavy alcohol use on balance, on memory, and on other sort of very basic functions. So it's interesting, the alcohol slide is a white man. The cannabis one is a black man. So we think of cannabis primarily smoked, although recently there have been a lot more edibles, which I'm happy to answer questions about. So anything you smoke, if you take a combustible plant material, it's a higher temperature, it damages like both the upper and the lower respiratory tract. When people smoke cannabis, they inhale it more deeply than tobacco actually. They hold it longer, so there's damage at the end part of the respiratory system. But similar, it also has an immunosuppressive quality, which makes individuals less likely to sort of clear infections when they get them, more likely to get it. It has some sort of reproductive suppressive qualities, both for men and for women. It is also associated with sort of demotivational, like attitudes, learning, impairments at higher levels of consumption. And the one particular thing I wanted to highlight was the relationship between cannabis and the development of psychosis. We have a good 10, 15 years of, at first observational and now prospective data, looking at people who smoke cannabis, especially adolescents, and the likelihood of developing psychosis, or more specifically, schizophrenia. And there is a relationship, and there's a relationship that's also somewhat dose dependent. So when we talk about causality in epidemiology, most things are associated that aren't causal. It's just by chance that two things kind of run together. But for an exposure, i.e. cannabis, to be causal of something like psychosis, there's certain criteria that we apply. One is that obviously the exposure has to precede the outcome, so cannabis before psychosis, and that seems to have been taken care of in the literature. But the other is a dose-dependent response. If you increase the exposure, the dose of the exposure, and that increases the outcome, that makes you think that association is actually causal. And that's what we see here, and that's what you see on the graph. As you increase cannabis exposure, the odds, and those are stratified by different articles, of psychosis increases. So probably, roughly, cannabis use has like an odds ratio about 2, which is not exactly a relative risk. So I'm making some really very basic epi errors in that part in this slide, so I apologize for those of you in the room. But if the baseline risk of psychosis is 1%, an odds ratio, relative risk of 2 means that now the individual has a 2% chance, doubles, the risk, which is small at the level of the individual. But when you think about at the level of the population, that relative risk actually leads to a larger population health burden. So heroin, we have a white woman depicted as the image on the poster for the harmful effects of heroin. And in this case, like it's sort of looking at injection, but clearly you don't have to inject opioids. You can smoke them, and more commonly here in the United States, you can use them intranasally. So anything you inject has impurities, has risk, has infectious risk to it. One thing we probably don't talk about as much is like the effect that opioids have on the digestive system, slowing down the digestive system, increasing the likelihood of, and in the reproductive, like for women, it suppresses menstruation, which suppresses ovulation, which leads to, some other sequelae. I'll talk about some of this in a second. But the one thing that I wanted to highlight of the harmful related to opioids is hepatitis C. The left-hand side there shows the number of reported cases to CDC of acute hep C infection in the United States, which is probably a gross undercount because on the right-hand side are the estimated using their own data. I want to highlight this too, AMFAR, if you're not aware of this website. They've compiled all of these data sources, and you can create graphs and maps, just like I have here for Hep C, also by, not just by state, but by congressional district. Which can be really handy ways to look at HIV, Hep C, opioids within your community. And here you see the state of Virginia, and you see counties which are considered to be high risk of having an HIV outbreak due to drug use. So those were all sort of harms on an individual level. But we can think about harms also, societal harms or harms to others. And the UK has probably done the best work with this, sort of looking at substances and classifying sort of the amount of harm to others and harm to the users, and then the total harm. And when you rank substances that way, alcohol is actually the most harmful, mostly driven by harm to others, related to motor vehicle accidents, violence, fisticuffs, etc., domestic violence, all of those things. Heroin is less harmful, although overall very harmful, but the proportional harm is more to the user than to others in contrast to alcohol. And cannabis is far lower on this sort of an organizational structure. Another way to think about harms relates to cost. This is a really nice this happens like every 10 years. They look at this national and state costs of excessive alcohol consumption. And you can see, and this is sort of stratified by healthcare costs, lost productivity, and other costs, including, which I'll talk about shortly, fetal alcohol syndrome. But you can see it's about $2 per drink in the United States of healthcare costs on the population, most of which due to lost workforce productivity, as opposed to criminal justice or health care or motor vehicle crashes. These are really large numbers. But this number is actually smaller than a recent estimate on the cost of opioids. This is from the Council on Economic Advisors from November of last year. And there's different ways that they sort of can estimate the costs, but most of it, the estimate's somewhere around $500 billion in the United States. Annual. And most of it is related to the overdose crisis, the loss, the fatality cost, the loss to society of the 75,000 people a year who die of a drug-related overdose. So I'm trained as an obstetrician gynecologist. I work mostly now in addiction medicine, but my primary interest remains sort of the intersection of gender and behavioral health. And there's been a lot of attention in the state too to neonatal abstinence syndrome, which is withdrawal of a newborn who is opioid exposed in utero, and less attention to fetal alcohol syndrome. So these are two tables that sort of contrast those two. About 10% of women drink some alcohol. About 5% of children are thought to be fetal alcohol exposed in school systems, and that's probably an undercount. And that number is higher on a population rate than the number of individuals with neonatal abstinence syndrome. We actually, overall, neonatal abstinence syndrome is an expected, treatable outcome of opioid exposure with really, we could have better data, but really no long-term consequences. Whereas where we think of alcohol is the leading preventable cause of intellectual disability in the United States. Whereas it costs maybe towards $100,000 to treat an infant with neonatal abstinence syndrome, although that number is decreasing, it costs well to $1 to $2 million to treat an infant with fetal alcohol syndrome. We know how to screen, we know how to treat, and clearly we are really, whereas we're looking at the opioid, and I think it's very important to look at the opioid, I think by looking at the opioid sometimes we're missing looking at other substances. So most of what I think we can do prevention-wise, public health-wise, is in that that low-use prevention, or what we call secondary prevention, which is preventing harms from escalating further in an individual with a substance use disorder. But I'm going to end by talking a little bit about addiction. So I've already said this, but not as directly. Most people who use a substance don't become addicted to it. These are data from the 90s that actually came out of researchers at VCU, classifying substances based upon their addictive potential, looking at the denominator is the number of people who've used something in the last year, and the numerator is the percentage who meet criteria for an addiction. And you can see about 1/3 of people who smoked a cigarette meet criteria for a nicotine use disorder, maybe 1/4 of people who used heroin meet criteria for an opioid use disorder, and numbers decrease from there. For cannabis, it's somewhere between 5 to 10% of people who smoked or used cannabis in the past year will meet criteria for a cannabis use disorder. So most people who use a substance don't become addicted to it. So why do some people become addicted and not others? The same is true here, for the opioid crisis, right? We overprescribed opioids. What percentage of those people developed an opioid use disorder? About 10%. Not a huge number, but considering how much prescribing we did, we created a large population of people with opioid use disorder. So why some people become addicted and not others? This is a complex question. But you guys have already you've already identified some of the vulnerabilities. So we've talked about genetics. About 30% of addiction cases are related to a genetic determinant at this point in time. Age of onset. The earlier you use something, the more likely you are to develop a use disorder. That's why it's one of the arguments for the 21 is the drinking age. Not that that actually is what happens in the population, but that's the argument for it. But the other thing are sort of trauma. Adverse childhood events, childhood sexual and physical abuse. At least half, probably more like, and for women, it's more like 70 to 80% of women with addiction have a significant childhood history of sexual or physical abuse. And also that related to development of PTSD. So if you want to think about prevention and the sort of intergenerationalness of addiction that's been raised, like one thing you could focus on is we should try to ensure that children grow up in environments that are safe and devoid of violence and stable. So when we take drugs, they enter into the brain in an old part of the brain. It's called the reward pathway. And dopamine is the transmitter that's released from it. And dopamine neurons go from this old part of the brain and project forward into the frontal cortex. So you can sort of see that's where behavior is and higher learning. So in many ways, you can see how NIDA talks about the hijacked brain, how the dopamine system interferes then with higher function, i.e. with behavior. So dopamine's released all the time, when we eat, when we have sex, when we run, when we feel good, when we do something well, and it's released at a certain level as depicted by those not kind of fuzzy little orange balls. But when you use a substance, dopamine's released at like 100 order the magnitude amount into the brain. So over time, what happens is the dopamine system is downregulated, is denuded. There's less dopamine that happens. People with chronic substance use and addiction produce far less dopamine in their brains than people without. And this is imaging, looking at that. The dopamine system, the like brighter colors means more activity, contrasting people without addiction to those with, and stratified by substance. And you can see across those substances a decrease in dopamine activity within the brain. So this was actually described for the first time, but it was the first article written on heroin addiction in the United States, in the world. And over here on the top right, they described, like, this is what happens when it's untreated addiction. Sick, straight, and high were the terms that they used. And people, you see that oscillating effect, it's a short-acting opioid. But over time, what happens is the person who, initially, the drug use made them high, quote unquote. Now they spend most of their time in that lower, most of the time in the sick category. And you could sort of say that addiction, which began as a sort of reward-seeking behavior, becomes a relief-seeking behavior through both you see it in the brain and you see it in the behaviors. So if we don't treat addiction, it tends to be fatal.
Mr. Chair.
Yeah.
Could you back up? Just
For that one?
one of the issues we see is people will get clean through some method, even if it's just forcible removal, but then when they get out, promptly and immediately go back to using. Is that, maybe one more slide back. So that's really interesting what you said, is at first it makes you feel good, and then after that, you just don't want to feel bad.
Yep.
30 days in, are you back to the first time out you feel good, or have you still got just don't want to tell us what the?
Yeah, so it probably takes 2 years for the dopamine system to heal in the brain.
Okay.
So
And-
30-day programs aren't that useful.
Yeah. So there's a couple. So that what you just observed. We have this artifact. Where did this come from? This like 28-day rehab, right? We think addiction's a chronic condition, right? Why do we have an acute intervention for a chronic condition? That makes no clinical sense, right? You can take somebody, put them in an artificial environment. There's a real role for residential treatment services, but you can put somebody in a controlled environment, i.e. incarcerated or residential or something, their behavior will change, they won't use, and then you put them right back where they came from, and 80% of people their disease will recur. So what we need to do is provide support and linkages and continuing care from that sort of higher intensity to the to the lower intensity. And really, from a recovery perspective, when we think about what recovery is, which I have some slides on, like recovery happens in the community. Recovery doesn't happen in, like the Malibu program. It happens like with your family, at work, and et cetera.
So if I could follow up, what
Yeah.
you're basically saying is a 30-day program would only work if it's tied to a longer term of
Correct.
probation and required reporting through a CSB or
Yes.
through some sort of.
Yes. Yeah, and linking people like quickly from discharge to continue. So we have like a system of care that you could think about that you step down through levels of intensity. Right, higher intensity to lower, to lower, to lower. And there's this really, Dr. Buckley mentioned this, a very strong role, I think, for peer services to help affect those linkages of care and to stitch things together.
Mr. Chairman?
Yeah,
So I think I just heard you say it, roughly at 30 days, the recidivism is still 80%.
oh, yeah, yes, if not
So
higher, yes.
Do you have data after, you mentioned 2 years, is there?
Yeah, so I will get to that in a second.
And then,
Yeah.
since you're going to get to that, and also if you could address the concept of of being dope sick, if as opposed to, which now is a public health thing, if there's something we could do to change people's behaviors simply in the yearn to avoid dope sickness, I'd be curious.
Yeah, so this is where Right here, that this bottom part here is what that sort of sick, straight high looks like for individuals who are receiving methadone pharmacotherapy. And so when we give somebody pharmacotherapy, it could be methadone, it could be buprenorphine, it could even be naltrexone. Where they function is in that sort of normal space. Not high and not sick, and it's long acting, so you can see that's why those the points are spaced like that. So I think there's a lot of role for taking people who present for care, i.e. at an emergency department, initiating them onto pharmacotherapy if they want that, and immediate transfer to continuing care in the outpatient setting. And that's one of the things we're working on at VCU, both clinically and under a grant, is to take people who present to the emergency department following an overdose. They've been reversed with naloxone. They're in withdrawal. So actually, it's a great time to give somebody buprenorphine because buprenorphine will, one, treat the withdrawal, two, provide an opioid blockade, which means if they do use again, they're actually protected from subsequent overdose, and three, provide what I call a pharmacologic bridge to continuing care in the outpatient setting. So I think there's lots of, opportunities within the healthcare system to address somebody clinically who is dope sick, i.e. in withdrawal, and both treat that and have that be the door that opens into treatment. So I'll go quickly. So addiction has been described a disease, a career of narrowing options, right? Your educational achievement is less than your peers, your workforce function, and if we don't treat it, and we're seeing this with opioids, we have overdose and overdose deaths.
Mr. Chairman,
Yep.
excuse me, I know we need to rush ahead, but I have to say the parenting failure, a expression that really has affected me is that no parenting, that the type of addiction that leads to just withdrawal from the world, no matter what is happening in the individual, means that a child that is born into that, not with the syndrome that we're talking about as far as the experience of drug while in the womb, but the fact that they're there and nobody's parenting them. And we have, with that, one of the spin-offs is that no one has ever treated them as a human being, socialized them. So the perpetuation of hard criminal acts that this is not my bracelet, it's a bracelet that I want, and I don't see, the criminal does not see me as a human being because the criminal has not been seen as a human being. And it's that non-parenting, not just the image of abusive parenting or the kind of child abuse, but neglect. And the final thing I'll say on that, close to accurate, that one of the Department of Criminal Justice's National Justice Institute, we'll get it right, close, long-term 20-year study, and what they found was that if the child was physically abused or neglected, and about 3-to-1 neglect versus a physical abuse, you had, I think, at least, I think it was 45% greater chance of being convicted of, not just committing, convicted of a violent crime. So it's that kind of lack of being treated as a human being that turns to this what we regard as amoral acts of violence that are hard to understand.
Yeah, I have two comments for that. One relates to something Joel said in the beginning about clinical care. I think at the crux of clinical medicine in general and taking care of people who use drugs and people with addiction in particular is treating people with dignity and respect. And that's really the core principle. I think treatment is really, it begins with empathy is the most important ingredient of treatment. And the second most important ingredient is adherence, people coming back to see you. And if you don't have empathy, they're not going to come back and see you. So I think there are ways, when we're talking about the top of the pyramid, the people with addiction, that we try to, sort of reflect that back. In terms of the other thing, I think it's really important public health-wise to mark a distinction between treated addiction and untreated addiction, right? So when we think, we kind of lump that in together. Our image of what addiction is actually the untreated state. And that's because most people don't get treatment. And so the difference from a parenting perspective, treated addiction is very different than untreated addiction. And the risks and sort of vulnerabilities and neglect that you're talking about, those come under untreated addiction, not under treated addiction. So it is, Joel mentioned this too, but we've looked at sort of the likelihood of relapse across disease states. And drug addiction, relapse defined as continued use despite treatment, the rates of relapse are similar to that for diabetes, hypertension, or asthma, which is evidence that supports addiction as a disease process. It looks like other chronic conditions. And this speaks to sort of like how far out and et cetera. So really the biggest predictor of recovery is abstinence and sustained abstinence. And you can see that it really takes like about a year of abstinence before less than half of people recur. And if you remain abstinent, up to 5 years, the likelihood of continuation of that is really high. So when we talk about treatment, really the goal of treatment is not more treatment, right? The goal of treatment is recovery. And recovery is more than abstinence. It's the inverse of the untreated addiction state. It's about meaning. It's about relationships of meaning. It's about purpose and connection and serenity. And it's perfectly compatible with the use of medications. So at Motivate, the clinic that we opened up, we really are trying to take a recovery-oriented lens to treatment, right? That we try to evaluate patients in terms of where they are in their recovery, not where they are in their treatment. It's related, but the goal isn't more treatment. The goal is recovery. So, and this speaks to this this is the image then of the 2-year mark, which is somewhat arbitrary. But you can see this is from somebody with a stimulant use disorder with methamphetamines, and you can see like the dopamine system. That's the normal control, which is 1 month of abstinence, where you can see sort of denuding, decreased dopamine activity across that part of the brain. And then at 2 years post initiation of treatment, that brain picture looks identical to the normal control. So even though there are brain changes associated with addiction with chronic opioid use, the brain heals, and it heals through treatment, and it heals through recovery. So I had some other comments to make, because I think, this is a conclusion slide, which relate to the clinic itself, to Motivate. And I really wanted to thank you guys, in particular, for supporting the arts benefit, the addiction recovery treatment services, the enhanced benefit for Medicaid, which really has, I think, launched this Commonwealth on a nationally visible experiment. And the experiment is, what happens if we pay and reimburse for addiction as if it really is a chronic condition? We have this, I haven't said one phrase, which everyone always says, that addiction is a chronic relapsing condition. And I haven't said that not because it's not true, but I think to some extent it's a chronic relapsing condition because historically we've only ever provided episodic care. People relapse because we don't continue the care. So is it the disease that's causing the relapse, or is it our care environment? It's probably both. But as we change the care environment, which we've been on this experiment now for a little over a year, I think the chronic relapsing piece of it will become clarified and actually won't be as large as some of the data that I showed you. The other thing to think about has to do with potency and with synthetics. So really, like showed how alcohol went from low concentration to high, and that's when problems happened. We're seeing this with cannabis, right? The THC concentration in the current types of cannabis that you can purchase, are markedly higher than they were 20 years ago, much less 40 years ago. And we're seeing this with opioids, with synthetic opioids, right? With fentanyl and other synthetics that are contaminating the heroin stream. And really, when you think about what is the future of harms and what is the future of use, it's looking more and more synthetic and less plant-based and higher potency. And that potency is related to risks, and it's related to risk of addiction and et cetera. So I'll stop and I'll answer some questions. Some more questions. Oh, and here's, yeah. Okay.
In light of a recent piece of legislation that came through last year regarding CBD oil, just want to clarify, when you say cannabis and you're talking the impacts on schizophrenia and stuff like that, our understanding is cannabis oil actually has an inverse effect than THC. Actually, that can be used for the treatment of schizophrenia as long as it's independently isolated from the THC?
Yeah, so within the plant, there are at least 60 different cannabinoids. A cannabinoid is anything that, we actually have cannabinoid receptors. It's, in many ways, there's a parallel to the opioid system, but we just know less about it because it was, as a opioid system, opioids have been sort of looked at for 150 years, cannabinoids for, less than 50. But we have a cannabinoid system. In the plant, there are at least 60 different cannabinoids. One of them, the 9-delta THC, is one of the psychoactive one and the main psychoactive one. Within the plant, there's this interesting relationship between 9-THC and cannabidiol, i.e. they're in an inverse relationship organically. So plants like hemp, which is in the same genus, has very little THC and a lot more cannabidiol. And what breeders have been doing is breeding stuff for the higher THC, and cannabidiol breeds the other way. So it's a little bit unclear, but from sort of animal studies and some other sort of brain imaging data related to cannabis or cannabinoids, it does not at all appear to be the cannabidiol that's associated with the increased risk of psychosis. These data that I showed you, it was just people who smoke cannabis, so they were getting both cannabidiol and THC.
Thank you.
Okay, a copy of this presentation.
Yes, sir. All the presentations will come to you all.
Tell the bell.
So, Doctor, this was sort of the walkthrough history was helpful. I do think there's a question. So most of us up here in our 40s or 50s or older, and we've watched sort of cycles of these
Yep.
addictive drugs. So we remember sort of the crack in the 80s.
Yep.
There's a period when meth was thought to be the thing. And then somewhere along we started talking about pills, and now it's heroin, and then heroin has sort of been segued to fentanyl. Most of those had all sorts of very dramatic impacts, so especially with crack in the 80s, but they weren't directly killing the user at the level we're seeing. The drug itself. I mean, for all the deaths, it was driving and danger and shootings, but it was not, I take too much of the drug and I die. Am I right with about that the heroin
So-
and then ultimately the fentanyl is
Yeah,
the death
so-
rate is up at a level that's different than all these other.
Yeah, if you look at overall drug overdoses, which include opioids, that they are at incredible rates.
Okay.
Yes.
So is that different? I guess does that give you some different thoughts about courses of treatment or how we can treat or what we can do? Because in other words, some of them, there are people that have addictions to other substances that are very unhealthy, and they maintain them over years or even decades, but it doesn't have this sudden overdose and they die and we don't affect. This seems much more urgent, if you will, or
Yeah. So
immediate.
a couple of things. One is that that although we focused a lot on the overdose, drug overdose, within drug overdoses, fentanyl. Leave that aside, which is really driving the increase in rate of drug deaths. Most overdose deaths are polypharmacology. it's alcohol or a benzodiazepine plus an opioid, or it's other, even some medications that people are on. And we're seeing a marked increase actually in drug overdose deaths with stimulants, both cocaine and amphetamines. And why we're seeing this now, I think it's the plus opioid piece that's driving that, whereas that plus opioid piece was not as much there during the 90s. The urgency for it, yes. And then if you want to think about what is the public health response, do you want me to answer that? So,
You got the podium. I'm not sure we'll agree, but go ahead.
So I'll tell you, I don't think it's concentrated on opioid prescribing guidelines. I think those are important, and I think we have to talk about pain, and we have to think about comprehensive ways to look at pain. But by restricting opioid prescribing, we're actually not going, and there's some estimates of this, we're not going to change the overdose data that greatly. The way we change it is by getting people access to naloxone, which reverses an overdose. So that's a short term, it's a Band-Aid, so to speak, but it can prevent a death, which is huge. And then two, by access to treatment, by markedly expanding access to treatment, in particular to evidence-based treatment, which is both behavioral health plus pharmacotherapy.
Could I follow up just briefly? There's almost an ideological divide in the treatment community, and I don't want to let them use that in the broadest sense of the term, between medically assisted treatment versus peer-to-peer treatment. And to the point where almost it seems as though they spend as much time yelling at each other as they do about other things. Do you have a position, or could you maybe share just general thoughts on?
Yeah, so I think when I think about what care should be for an individual and for a system, care should be both evidence-based and person-centered. And when person-centered conflicts with evidence-based, well, ethically, you go with person-centered care. So people have the right of refusal of pharmacotherapy, and that's important. And just because somebody doesn't want medication, when I see them in clinic, we still see them. It's not a prerequisite. We know from the evidence base that people who, that adherence with treatment is increased with pharmacotherapy. We know that medications decrease the likelihood of overdose and overdose death significantly. And when people stop taking medication, they're actually at a higher risk of dying than they were before they initiated treatment. Now, I think one way around that divide that you describe is actually by looking at all of this from a recovery-oriented perspective. Right? The goal of treatment isn't more treatment, it's recovery. There are many paths to recovery. Evidence-based pharmacotherapy treatment is one of the paths, but there are lots of people who are in recovery who never touch the treatment system. And that doesn't mean that treatment doesn't work. It doesn't mean the only way to get to recovery is not going through treatment. It just means that actually there's a lot we still don't know about the illness state and how to treat it across, somebody's lifespan. So I think the goal is recovery, and how you get there and how you support somebody there is the most important thing. Knowing that the tools that we have, we should use them. We should expand the use of them. But it's not like there's only one way to get to recovery, and that way has to be through medication. I would never say that. But I would say it's it's the evidence-based, that's the science. And that's what we should support as a public health enterprise.
Doctor, have you ever talked to a group of judges or lawyers?
Yes.
I would suggest that it might be useful to talk to the Chief Justice, and you make a presentation to the judicial conference that you have not.
Yeah, I've talked to some of the drug court judges and the family court judges. It's, I think I learn a lot more than they do from me, which is always the sign of a good experience.
Okay, thanks very much.
You're welcome.